Hello, I'm Rohit Gosain, a community medical oncologist, alongside my brother, Rahul Gosain, another community medical oncologist, and we are the Oncology Brothers. Today, we are talking about the clinical insights on how this field is moving. In 2025, we saw multiple drug approvals. However, one of the more impactful one was perioperative Durvalumab with chemotherapy, based on Matterhorn study. To talk about that and data in hand and more, we have a great panel, starting out with Dr. Stephen Maron from MSK, Dr. Reetu Mukherji from MedStar Georgetown, Dr. Angela Alistar from Atlantic Health, and Dr. Raji Shameem from Orlando Health. Welcome, everyone.
Thank you for being here today. Before we get into the Matterhorn study, just as background, when it comes to early disease for G junction or gastric adenocarcinoma, historically, we've been worried about local control. That's where cross-trial came in with concurrent chemoradiation. And we quickly realized that it's actually the micromets that we have to worry about. That's where ESOPEC reaffirmed that this should be the standard of care. Peri-op FLOT, surgery, and then post-op FLOT. Then the question was, how can we do better? That is what got Dervalumab FLOT, surgery, Durvalumab FLOT, and then ongoing Durvalumab with Matterhorn approved. Let's start there. Steve, can you start us off with the Matterhorn study design, which led to the approval of Durvalumab in this space?
Absolutely. So with Matterhorn, patients received FLOT4, our standard paradigm now, for many years with 4 cycles of FLOT prior to surgery, followed by surgery, and then 4 cycles afterwards. In this case, patients also received either Durvalumab or placebo, and this is a randomized trial. What's also unique here is that not only did they have the concurrent Durvalumab for the 2 months pre-op and the 2 months of adjuvant concurrently with chemotherapy, but then an additional 10 months of adjuvant Durvalumab alone as well, every 4 weeks.
Well, Steve, thanks so much for laying that foundation. Ritu, what we saw initially presentation was at ASCO 2025, and then we saw updated data at ESMO 2025. Could you go over the findings that we learned from ASCO as well as ESMO with regards to Matterhorn?
Sure. So the initial data that we got from this randomized phase 3 study was really the pathologic complete response data at first. And what we saw is that compared to perioperative or neoadjuvant FLOT alone, FLOT plus Durvalumab improved the path complete response rate from about 7% to 19%. So we saw a signal that there was more effect at the local level based on path complete response. And then the more recent data that was presented was actually one of the primary endpoints, event-free survival. And they reported data at the 18-month and 24-month mark for event-free survival. And at 2 years, we saw the EFS was about 59% compared to 67%, a delta of about 8%, which really affirmed that perioperative FLOT plus Durvalumab was a superior arm in this randomized study.
Thank you for touching on that. Coming where I started with that local control, I think that PCR is impressive. However, to see that event-free survival, to see that overall survival address the micromets, I think is a lot more meaningful in this particular settings. Angela, one thing that we always worry about is anytime we're adding a new option in the peri-op settings, is this going to compromise my surgical outcomes? Thankfully, that was not the case. Can you build up on this a little? What did we see with the control and the Durva FLOT arm in terms of the surgical outcomes?
Yeah, I think it's an easy decision to make by medical oncologists because the toxicity of the combination doesn't really come as much from the immunotherapy, but it comes from the chemotherapy. We are all now proficient in managing FLOT toxicity, so adding immunotherapy doesn't really fluster the medical oncologist very much. Of course, autoimmune toxicity can happen, and it will happen in some of the patients. But anytime I have to present FLOT toxicity and immunotherapy toxicity, it's really very clear that the toxicity will be mostly driven by the FLOT, by the chemotherapy combination. And that is what gets modified most of the time. From the clinical trial results, the autoimmune toxicity did not lead to any kind of inability to go to surgery, did not exclude patients from surgery. It was not added toxicity that would make the surgeon concerned or the medical oncologist or the patient. So I think in the neoadjuvant and adjuvant setting, immunotherapy did not translate into higher toxicity or impacted survival negatively. So I think it's a very easy to adopt regimen from that standpoint.
Yeah. And to put it in clinical context, in both arms, roughly about 10 to 15% did not make it to the surgery.
Right.
So when we're comparing it to FLOT versus Durvalumab FLOT, it was encouraging to see that we're indeed, thankfully, not compromising those surgical interventions.
Yeah.
Raji, in our discussion with Dr. Yelena Janjigian, who was one of the top leaders who participated in the clinical trial, she mentioned was that she has not utilized chemoradiation therapy approach in past 7 to 8 years, and rightly so, because now we have learned better to manage the FLOT regimen with dose modification. So we'll have to broadly agree where we stand that with this impressive data, that is rather the new standard of care, and we have adapted this in our practice. The question is, who is not that patient that you will utilize this therapy and rather consider chemoradiation?
I think that's a very relevant question. We want our patients to have the best outcomes. We also want to acknowledge toxicity that occur. But as you mentioned, the addition of Durvalumab to chemotherapy, not much difference. And yes, there are those rare immunotherapy adverse reactions, but overall, as we saw in the trial, majority of patients were able to undergo surgery, and a large number of patients were able to complete adjuvant therapy, including those 10 additional months of Durvalumab. I think there are certain patients who are not candidates who would not be able to receive any immunotherapy agent, right? Active autoimmune disease, Crohn's, ulcerative colitis, those are the ones who will never get it. But I always feel like 3 drugs matter. I know I've been using FLOT for a while, right? I believe docetaxel, 5-FU, and oxaliplatin, it makes a difference, right? And in my practice, I try to offer all my patients those drugs, acknowledging dose reductions might be required, right? And when I have the discussion regarding the outcomes, I would say we can try it, right? If there is, I'm not worried that they might have to stop the thing, but I offer it, right? But absolutely contraindications of immunotherapy, that's one reason. But majority of patients, I feel they're candidates acknowledging dose reductions and stopping chemotherapy might happen.
Absolutely. So keeping all this in mind, clearly the new standard of care. Stephen, let's take a little deeper dive here. What's your clinical practice? Are you checking that PD-L1 positive or negative status upfront in these early settings? And are you using that PD-L1 to make that decision? Because in hand, the FDA approval is for all comers. The data supports that for intent to treat overall population is also positive. What's your clinical practice?
I love that question. We actually do an incredible amount of testing up front. And for all of my patients with esophageal gastric cancer, I'm testing MMR, which I think is most important to decide. Am I giving FLOT or immunotherapy alone?
Absolutely.
We're testing PD-L1, HER2, as well as now Claudin 18, recognizing there are no approvals there in that space. But oftentimes when we're doing the testing, it's before we've even done the additional PET, diagnostic laparoscopy. We're still sorting out their staging, right? So we then have it on hand, typically also doing tissue and plasma NGS at that time as well. So although I am using the PD-L1 testing up front, basically everyone is getting it now. All right. We currently have the NCCN stating a cutoff of 1 or higher, but now in the face of this approval, regardless of PD-L1, we will be using it in pretty much everyone unless they have an active autoimmune disease, which then gets into, would you withhold it then? Risk-benefit discussion, how high is the PD-L1? Are they microsatellite unstable for just immune checkpoint blockade? And the most important question I find is talk to the rheumatologist, right? And is this something that historically you've been able to control easily in the past?
The majority of the patients are PD-L1 positive, and even in that autoimmune, as you mentioned, if the disease is actively controlled and there are no exacerbations, we are utilizing immunotherapy in those settings. Reetu, what Angela and Raji mentioned with regards to the side effect profile, which is mainly coming from the chemotherapy aspect, we do proceed with dose modification, whether that's 15 to 20%, and still add the Durvalumab. Any clinical pearls around that? Because again, the FLOT regimen, we know that it's not the easiest one to tolerate. It has nausea, neuropathy, alopecia. Thoughts on that, please?
Yeah, so I think in most patients who we think can tolerate these therapies, I try to give the full doses of FLOT up front with Durvalumab added. If I have a frail patient or someone with some other comorbidities, cardiac comorbidities, I may think about dose reducing the triplet regimen by 15-20% all drugs with full dose Durvalumab. And in some patients who may be starting with a lot of neuropathy from other comorbidities, can consider even potentially dropping docetaxel and proceeding with 5-FU and oxaliplatin alone, but the immunotherapy component added. And I think it's very important understanding that, we do see things like nausea, diarrhea to counsel the patients on this upfront and make sure that they're given the proper antiemetic prescriptions on hand before they start these therapies, and making sure we're aggressive with the pre-medications on the day of treatment and making sure they have a good schedule for day 2, 3, 4 at home prophylactically. And, I think we all have different regimens that we use, but I typically give dexamethasone day 2, 3, 4, Zofran standing, BID for a couple days, Ativan if needed, and then certainly we add on that with even antidiarrheals as well.
Absolutely. The other thing, of course, being aggressive with hydration as well for these patients. Angela, can I just build up a little more on that frail patient that Ritu mentioned? In that pre-op settings, patient got flat in Durva, went through surgery, but you are leaning towards decreasing the dose or perhaps omitting that chemotherapy in that post-op settings. Would you feel comfortable then just continuing Durvalumab alone in that particular settings?
I would feel comfortable. I actually have a patient experience like that. He really was highly anxious, I'll say that, and did not like that he lost weight with the surgery. And he was extremely concerned about how much more weight is he going to lose. And despite of my, full education of the benefit of still having adjuvant modified, I was willing to modify chemotherapy in any way. He really opted for immunotherapy only. He did not want to have the chemotherapy. So, this is a partnership with the patient, and we have to listen to their goals, what they're hoping to achieve with the treatments. And instead of saying no adjuvant whatsoever, immunotherapy is the easy treatment to give anyway. I think it is appropriate, even if a patient chooses to stop the chemotherapy, or if they need any kind of modifications. I think in my practice, any adjuvant treatment I can give is justified in this setting, and I will modify it based on the patient's fitness level and performance status post-op, their ability to eat, their goals really, and function level expectations. But that is really what I've seen so far. Most patients do want to have the whole treatment though.
Well, keeping the side effect profile in mind, Raji, we tend to omit 5-FU bolus out in metastatic space because of, again, myelosuppression, diarrhea, and other side effect that is tied in. Do you do that in your practice, even in this setting, which is curative in FLOT-based therapy?
I have a really low threshold to admit it. I think a lot of the toxicity, even like early diarrhea and stuff, it makes a world of a difference. And
Well,
with
the
the additioning adding the taxane, it's even more pronounced. So low threshold.
And of course, in community practice, we are well versed with managing immune therapy related side effects. Anything to add, Raji, from your community practice itself, managing or clinical pros around immunotherapy related side effects?
I think it's that discussion with the patient. A lot of them have the perception it's immunotherapy. It does not have side effects. We know that's not the case, right? I tell my patients any organ in the body can be inflamed. And a lot of these symptoms, you don't know that it truly is immunotherapy toxicity. So I tell my patients if there's anything new or concerning, let us know. Acknowledging that early recognition, actually making the diagnosis can prevent severity, and actually it makes a big difference. So anything new, let us know. So our lines are very busy in our
Indeed, the side effects, that's educating the patient as well as the staff so they can better equip the patient, whether we have to utilize steroids early on itself. Stephen, with regards to the hot topic, which is undertreatment versus overtreatment. Again, we are talking about the side effects because it comes along with that, and then we add financial toxicity as well. Any role of ctDNA to guide your treatment here with regards to undertreatment and overtreatment?
Great question. Um, I think one of the things we struggle with is we're always trying to do the adjuvant therapy because we never want to jeopardize curative therapy, right? And what we learned from space flaws, so retrospectively looking across the European cases, was patients who had a pathologic complete response didn't really seem to get much benefit from the addition of adjuvant chemotherapy alone. Patients with absolutely no response didn't really seem to gain any benefit. And that sort of makes sense, right? So if I see a patient on either extreme, they're slowly recovering from surgery, they're having a lot of toxicity, my threshold for relying less on the chemotherapy, maybe focusing more on getting the Durvalumab in, is much higher, right? Because I just don't think the risk benefit is as favorable for them. Patients in the middle, especially if there's any evidence of either clinical or pathologic regression, then I lean more into the chemo. In terms of the ctDNA, though, we published this a few years ago, actually, looking at the fact that if you have detectable ctDNA after surgery, you're unfortunately going to do quite poorly. Your risk of recurrence is nearly 100%. The problem is most of the assays that we have, the sensitivity is just not as adequate as we'd like. We have 80% sensitivity, I'd say. So I don't really trust the negatives because of that. Though it does tell me pretty conclusively that the patients with positive ctDNA, if I have a creative option, a trial, I will absolutely push for that. Otherwise, I just sometimes recognize that and emphasize to the patient that if I do have a test like this, that's positive, which I do not do routinely, that you'll likely need more prolonged therapy because we're treating micrometastatic disease, and it's unclear that pushing the envelope with FLOT is in their best interest if they already functionally failed neoadjuvant FLOT there, right?
Absolutely. And again, what you touched on it, ctDNA story is a hot topic in every disease site. Not ready for prime time here for us to make clinical decisions. Ongoing Durvalumab is indicated regardless of that test. Ritu, we have data in hand, but that real practice looks a little different. Can you walk us through what does that multi-D tumor board discussion looks like with that surgeon? Are you seeing similar numbers that majority of our patients are going through surgery with Durvalumab FLOT? Walk me through your clinical practice and that multi-D discussion for us.
Sure. So the majority of patients at our practice, they are first diagnosed through gastroenterology. They then meet with the surgeon and then are really referred then to medical oncology. And then as a group, we try to get all the staging. And for, locally advanced gastroesophageal gastric cancer, it's important to get the CT scan, EUS for proper TNN local staging, and then a diagnostic laparoscopy as well to rule out occult peritoneal disease. And then certainly we're running the biomarker testing in the background during that time. So once we have all that information, we bring that patient to a multi-D tumor board. We really take a close look at the scans in detail. And I think that's so important to do because there's so many nuances to surgical planning and actually looking at the images and where the tumor lies, where the epicenter is. And we really try to get an assessment from our surgeon is this resectable and are they likely to get a margin negative resection and what is the operation that will be offered? And once we have all that information, I think the majority of us appreciate perioperative chemotherapy, and now with immunotherapy, it's a standard of care. We may talk about this later, but there may be select cases where radiation may be incorporated down the line. But for the vast majority of patients, it is perioperative chemotherapy with immunotherapy. I don't think the rates of that have really changed recently, and from what I have seen. But I think it's very important to have that multi-D tumor board review because there's so much nuance to even just knowing what kind of operation is offered, and what you should be looking for after those first 2 months of neoadjuvant therapy on your scan to kind of guide the next steps.
Ritu, thanks for touching on that. Again, multi-D is at the center of all this. Angela, you also brought up some side effects that we have to keep in mind. FLOT's not the easiest drug. Steve, can I come back to you for this one? FLOT is not the easiest one, but in post-op settings, it's even harder.
Absolutely.
Is there a particular patient where instead of 4 cycles, you're thinking of giving all your upfront chemoimmunotherapy, take them through surgery, and then perhaps just immunotherapy thereafter as a single agent?
Sometimes we will. It's very challenging, and we're a little bit hesitant to do it. So when we think of patients with a very extensive primary tumor where we're afraid that this is T4 disease, that even getting a total gastrectomy will be challenging if we think it's encroaching upon the pancreas, but we think it's still technically resectable, negative cytology, or even just it looked like we thought the cytology would be positive, but it's not, right? These are the patients where we're saying we want to see a longer period on systemic therapy just to better understand the biology before we take them through a total gastrectomy, a life-changing surgery. We published our experience with this and recognizing its retrospective, incredibly biased population, and this was before Matterhorn. The concern was that they actually seemed to do worse with total neoadjuvant therapy with TNT. So with that, we've been a little more hesitant to do so. In these cases where we're worried about taking them to surgery, then have a few options. So one, I'll push them a little bit further and push until they say, this is sort of enough. Typically ends up being about 5 or 6. We don't know that 6 months of therapy is better than 4, is better than 3. We have no idea. But we're also looking at how we change the paradigm even more, like with HER2 positive patients. We'll now on study or even off, do double chemotherapy with PD-1 with HER2 blockade as well for a more prolonged period of 4 to 6 months, again, to treat the biology, and seeing great benefit with that.
So as of now, your clinical practice is sticking with what we've seen in the clinical trial. And I want to come back to that design for a second as well. When you're looking at the trial design, it says 2 cycles. It's 2 cycles for Durvalumab. Within that, built in are 4 cycles of FLOT, which you mentioned. So,
And Angela, with that background in mind, now we know that what we are agreeing that this is in fact the standard of care for all comers. If the disease was to progress while one is on immunotherapy or shortly after immunotherapy, what next, especially when they've seen the immunotherapy up front?
So if they progress in the neoadjuvant setting, I think that would be, it would either make them not surgical candidates, which really I think would reflect the fact that they were metastatic to begin with.
Sure.
And they failed basically
systemic.
first-line treatment, because if they're metastatic that fast, they were probably metastatic. So then I would look either for a clinical trial, I would look at their molecular profile to see if I can target anything else, and or second-line treatment for metastatic disease. That would be my approach if they progress in the neoadjuvant setting. Now, if they progress in the adjuvant setting while at the end of, let's say, chemotherapy with immunotherapy, that would also be sort of reflective that they probably had metastatic disease all along, that the surgery further immunosuppressed them, and now we kind of see the full expression of the biology. So definitely I would be looking for a second-line treatment now, because they failed a fluorouracil-based regimen. If the progression of disease would happen on immunotherapy only, that would also be sort of kind of the same idea that either chemotherapy was very effective at controlling micrometastatic disease, and that's why now off chemotherapy they're progressing, which means they were micrometastatic all along. So again, I would be looking for a second-line treatment. So progressing at any time point is not a good idea, and would, in my opinion, mean failure of the Durvalumab with FLOT, and I would be looking into something else.
Certainly that presents as an aggressive disease to begin with. So again, biomarker testing, NGS is extremely important.
Rohit, as community oncologist, this is not just a problem here in GE junction or gastric cancer with the sandwich approach. NIAGARA trial got Durvalumab approved in bladder cancer.
Right.
Similar question. In lung cancer, we're doing the peri-op, post-op IO approach as well. Similar question keeps coming up. What are we doing if the disease was to progress post-IO exposure?
We do have a sort of a parallel example with the cholangiocarcinoma, right? We have 2 studies. One is adjuvant gemcitabine with pembro, and the other one is pembro only. It's not adjuvant, it's maintenance. And we see that sometimes patients on immunotherapy lose their response to treatment. And it begs the question if a little sort of chemotherapy doesn't help maintain that response. We don't really know the answer yet, but I think there is something to say about patients who progress fast. It's either biology or immunotherapy alone is just not going to hold the response.
And again, right this minute, we're in this data-free zone because Matterhorn just got approved here in 2025. So we're going to be learning as the data continues to mature more.
We have covered quite a bit here. Raji, if you could go over some of the clinical takeaways from what we learned from Matterhorn and able to apply to our practice today.
I have to say, a really important trial, elegant trial. Many of our upper GI trials, they lumped a lot of different cancers. Like they had squamous cell, you don't know which types, and it truly wasn't global trials, where it's either Asia specific or a different part of the world. But this was truly a global trial. They included GEJ gastric cancers, right? And also they stratified really well. They included patients also with PD-L1 negative. And I think that's really important for me because when I first recommended the regimen, it was prior to the FDA approval. Because of the efficacy, the NCCN mandated you need to have PD-L1 expression. And, in the community, you don't always have those results, right? But I'm really happy that the FDA approval was based on the ITT, right?
Of course.
Where, in the clinic, you have a patient with upper GI cancer, they're symptomatic, you want to get started as soon as possible, right? Do you want to wait for that PD-L1? So for practicality and being in the community, it was a good decision. It allows me to make the decision at the time of consultation, and just the efficacy and the safety it's truly a game changer. It has changed the standard of care for resectable gastric and GEJ cancer patients.
Can I just build up and then I promise we'll close the lumping story. Steve, the Durvalumab approval is for GE junction adenocarcinoma and gastric adenocarcinoma. Are you extrapolating this for esophageal adenocarcinoma as standard of care?
This is something that we've needed to put to rest for a very long time. Molecularly, there is no difference between distal esophageal and GE junction tumors. We've known this for a very long time. We've had this surgical paradigm with a distinction. And thankfully, the stage was set for Matterhorn by ESAPEC, which put chemoradiotherapy to rest. And so now we can say for all of this singular cancer that we're treating it the same way.
And in fact, there is no true esophageal adenocarcinoma. There is always some involvement of GEJ aspects. So again, at the end of the day, it can be extrapolated indeed.
And a lot of us are doing that in our practice. So I'm glad that we had a chance to lump that particular subset together. Again, here, Dervalumab with FLOT is now this new standard of care for that resectable GE junction gastric adenocarcinoma based off event-free survival, based off overall survival. And yes, coming back to that, PCR is also improved here. Steve, Reetu, Angela, Raji, thank you so much for taking the time and walking us through this data for this approval here in the settings.
Thank you.
Thank you for having us.
Thank you so much, guys. Thank you, guys.